In these sessions, we will discuss about the strategies for non-communicable disease prevention and control. Dear friends, as you are aware that non-communicable disease is the one of the major area in our healthcare system. In our earlier days, the more that are used to be because of the infectious disease, but in this gradually development of the civilization, this prevalence of the non-communicable disease is gradually increasing, and the deaths due to the non-communicable disease like cardiovascular diseases, cancer, accident, all these things are gradually increasing and overtaking these infectious disease. To discuss all this issue, today we are having Dr. Anand, Associate Professor, AIIMS, Center for Community Medicine, and I would like to request Dr. Anand to discuss the strategies for prevention of non-communicable diseases and how to control them at the national level or at the district level. You may kindly, sir.
Thank you, Dr. Jamatia. As Dr. Biplab just said, that we have been used to working in the areas of maternal child health and communicable diseases, and only recently have we started addressing non-communicable diseases. There is still not yet a good comprehension about how we manage or handle a non-communicable disease at a population level. It is still looked at primarily as a clinical, where doctors or cardiologists or diabetologists or neurologists for them to handle, not really seen as something that a public health approach is required. So I would be largely focusing on how we can address NCDs as a public health approach, and you will find some similarities between my talk and what Dr. Desai talked to you some minutes back. He also looked at how public health approach for mental health diseases. So largely both of them would be similar, and many of the points that I will make would probably reinforce what Dr. Desai said in your previous lecture on the most important thing he said is that mental health is too important to leave it to psychiatrists. So similarly, the message that from my side is that either it is heart disease or stroke or cancer are too important to be left to cardiologists or neurologists or diabetologists. The general belief is that NCDs do not cause a major share of the burden of deaths in not only in India but in all countries, developing countries. But you might be surprised perhaps to know that now NCDs contribute to more than 50% of deaths in India as well as in many of the developing countries. So clearly NCDs have overtaken maternal child health and infectious diseases and injuries as the most important cause of death in this country. There is still some perception that most of these deaths occur actually at an elder age group. It is occurring at above 70 years, 80 years, and to some extent it is definitely right. Obviously most people who contribute to this chunk good number of them are above 70 years, if you take 70 years as a cutoff point for a productive life. But still a fairly large proportion of these deaths occur in younger age group, especially in countries like India, where as you must have seen, we see a lot of young cases of stroke or heart diseases or cancer. So it is no more a disease of Western world, it is a disease of developing countries, it is a disease of younger people in these countries. And if you again look at this slide, it shows the different contribution of different diseases within NCDs. There are 4 major NCDs that we talk of: heart diseases, cancer, diabetes, and chronic pulmonary disease. So these are the 4 major disease groups which we talk about in NCDs. There are a lot of other NCDs also, but these are the 4 major groups that we talk of. And as you can see that they constitute almost 53% of deaths in India, only 36% being contributed by communicable and 8% by other, and 11% by injuries. And out of this, almost 28% is cardiovascular diseases, which include both heart diseases as well as stroke is a part of cardiovascular disease. So these two together are the most important killer within the non-communicable disease that we talk of, followed by chronic respiratory diseases and cancer. And as you can see, these are the estimates prepared by Government of India in the National Commission of Macroeconomics and Health, where it shows that this is not, now itself we are saying that 53% of deaths are due to NCDs. These estimates show that this is going to increase. All of the, except RHD or rheumatic heart disease, which is not really in that sense a non-communicable diseases, it has a communicable origin, are expected to increase in next 10 years, or rather from the next 10 years, in next 5 years, as you can say, they are going to increase, and therefore they are not only a big problem now, they are going to become more and more of a problem in the coming years. Increasing also the morbidity. These are again estimates from data on India prepared by the National Commission on Macroeconomics and Health. Again, we can see that stroke, cancer, CHD, diabetes, COPD, all of them are showing are likely to increase over the next 5 years. This is data from Bangladesh, which shows that diabetes is rising much faster than, even in India there are evidence that diabetes is going much faster, especially in South India than in the northern India. But even in rural areas now we are reporting a prevalence of diabetes in the range of 5 to 10% and in about 10 to 15% in the urban areas. So clearly this was not anticipated even in some years back. And if you look at compare our experience with the Western experience, we can see that they have started showing a decline in most of these diseases. So while we are showing an increase in NCDs, Western countries, among in many parts of the developed countries, as you can see in given here, whether it is Brazil, USA, Australia, Canada, UK, they all have started declining since mid 70s to 80s. So we are roughly about 30 or 40 years behind them. Unless if we want to show a similar decline in India, we want to see a decline, we need to do something now. Otherwise, this will keep on rising and will probably rise higher than what was the reported rates in many of the developed countries at their peak. Our peak might be higher. Fortunately, we are at an early stage of this epidemic, and if we do take a precaution now and take steps now, we are unlikely to reach the peaks which the Western countries reached. So there is a time now, but the window is fast closing. Unless we do something now, this is not going to happen. The other important thing of NCDs is, which is true for many other health issues also, are there are major differences, whether it is rural, urban, male, female, or by education. So there is also an issue of equity, and NCDs are also an equity issue because they, despite the general feeling that the NCDs are not a problem in poor, it is in fact not true. They might be less, but they are definitely more in poor. They are also maybe less in rural areas, but by no means are they not a problem in rural areas. Even as I said, the diabetes, the rates in many rural parts in India are almost 5%. No, anybody who works in public health area would tell you that 5% prevalence of any disease would needs a serious attention of any policymaker and a program manager. So again, sex differentials, many of these have, most of these diseases have sex differentials, and which needs to be taken into care when we plan programs. Many of the risk factors, and I will repeatedly talk about risk factors subsequently also, are even now higher among poorer people. Today's risk factors are tomorrow's disease. So unless we do something now, tomorrow the prevalence of these diseases are going to be higher among poor people. Now it is lower, but it is not maybe in 5 years, 10 years time when these risk factors get translated into disease, which is bound to happen. Unless we do something, this is definitely going to happen. The poor people are more likely to have prevalence of these diseases. The rich have already started taking some corrective action at individual level, not at the public health level. But we know in this country that many of the richer people have started adopting much healthier practices, whether it is in terms of diet, whether leaving smoking, or doing more physical activity. So that change has occurred at the highest socioeconomic status by an individual effort, not by a government or a public health effort. But poor people cannot afford it, they cannot do it, and they currently continue to have high risk factors, and therefore they are likely to be burdened with much higher rates of these diseases subsequently. So as an equity issue, government has to intervene. Public health approach has to be done. Again, as I said, why talk about risk factors? What is a risk factor? So risk factor is any individual attribute or exposure that is positively or negatively associated with the occurrence of a disease. Here we are mainly saying of positively occurrence, so that because they result in causation of disease. So presence of a risk factor is always, it has to be a preceding event. It precedes the development of a disease, and therefore you can predict. There are some risk prediction charts. You know that if you are a smoker and if you smoke for such year, there is such and such probability of you developing a disease. If you are a smoker, you have some other risk factors. So more the number of risk factors, higher is the probability of you developing the disease. And the risk factors can be grouped into three types. We call them behavioral risk factors, physiological risk factors, and biochemical risk factors. These are the three grades of risk factors. The first is risky behaviors, as you see on this slide. They are behavioral. There are basically four major behaviors that we look at: tobacco use, alcohol use, diet, physical activity. Just four behaviors are the most important for addressing most of the NCDs, whether it is heart disease, cancer, COPD, stroke, anything. You talk of, all of them are related to these four major risk factors. These two result in two physiological status, which are obesity and hypertension, which result in more biochemical this thing, which could be either hyperglycemia or diabetes and hyperlipidemia. So these four behavioral, two physiological and two biochemical risk factors are responsible for most of the non-communicable diseases that we talk of. As you can see, this slide shows the relationship between different risk factors and the 4 major NCDs. And you can see there is these 4 diseases share many of these risk factors. And therefore, there is no need to have a cardiovascular disease program or a diabetes program or a cancer program or a respiratory disease program, because all of them will ultimately talk of the same things. Therefore, it is important to focus on risk factors and not really have vertical disease specific programs. As long as our programs address all these risk factors, whatever you may call them, it will result in the same thing. We may have a cardiovascular program, but if we address these risk factors, it is going to prevent cancer also, it is going to prevent stroke also, it is going to prevent COPD also. So as I said again, 8 risk factors. If we just remember these 8 risk factors, they almost are responsible for 80% of all the NCDs that we are talking of. And these are the data generated by WHO on looking at what are the important risk factors. This report was published in 2003, where they looked at major risk factors for health, all health put together, not only non-communicable diseases. And you can see the 3 most important are, this is at national level, global level: high blood pressure, tobacco and cholesterol. The ones in the red one are high mortality developing countries. India falls right now in high mortality developing countries. So even in that you can see the two most important are obviously malnutrition and unsafe sex, but still you will see that high BP, cholesterol, tobacco are all within first 5 or 10 of the major risk factors to poor health in our country. The other thing is, there is one more column. This again has diseases, intermediate risk factors, behavior, and then goes one more level behind. Why do people have these risk factors? As we say, disease is because of physiological and biochemical reasons. These are because of behaviors. Then why are people having these behaviors? Why people smoke or take unhealthy diet or do not practice physical activity? This is because of underlying socio-economic, cultural, political and environmental determinants. This is very important to have, understand that people behave like what they are behaving, not because they want to behave like that. It is not an informed choice that they are making. It is because they are living in an environment which either encourages inappropriate behavior. I would say smoking is a very good example, where especially in rural areas, which encourages smoking, or it does not sufficiently discourage inappropriate behavior. And therefore it is important, if you want to change behavior, we have to look at these kind of issues, whether it is globalization, whether it is urbanization, whether it is epidemiological transition or population aging, demographic transition. So which is what, so you need to know that you all living in India are seeing that India is undergoing a major transition which covers a lot of areas. Whether it is demographic transition, we used to be much younger population, we are gradually becoming a much older population with increasing life expectancy. So we right now have both the burden. We have a lot of young people, at the same time our proportion of elder people are increasing. Epidemiological transition, where we have communicable diseases are going down, and therefore automatically the share of NCDs will go up in terms of mortality and all. Globalization, the marketization which is occurring, commercialization, the media, role of media, the changing lifestyles, especially in urban areas, and gradually this is creeping into rural areas. So, and all these are driving this change in behavior. And unless we address these changes, there is no way we can change behavior. Behavior is not an individual activity. Behavior is something that all of us behave in the way that we want to look good in the community. We all want to behave as what is appropriate or what is normal in a community. And how we define what is normal in a community is what most people do. So if in a community which most of them smoke, smoking is a normal behavior. So there will be no impetus or no incentive for anybody to stop smoking, because they consider smoking as a normal behavior. So unless we change this concept of normality to abnormality, if you make smoking an abnormal behavior, then most people will automatically stop smoking without, you don't have to do any program, you don't have to do any other activity. The whole challenge is how to make smoking unattractive or not considered as a normal behavior. And you can see many of the messages, media is, we are trying to do that. But we have not succeeded till now, but still it's a process which has started. Again, urbanization, which is changing in dietary habits, even in rural areas now, many of whether it is Maggi or whether it is burgers or pizzas, so there is a major change occurring in our diet. And unless this is changed, the incidence and the number of cases of NCDs is going to increase. And again, how do we change this? It is not an easy, because it is now globalization. There's no way you can stop big companies like whether it is McDonald's or whether it is KFCs or many other multinational companies which are coming in on all these kind of things too. There is a very strong market, they see India as a big market, and there is an enormous amount of money which is being pushed into these kind of food products being sold in India. How do we control them? How do we regulate them? Can we regulate these advertisements? Can we regulate the opening of these? We don't have similar push for, say, more parks in our country. Are there anybody taking up issue of developing more parks or more gymnasiums by people? Because there is not sufficient market, or it is not seen as a commercially successful venture. So what is driving now the changing behaviors is these commercial interests, and we have to balance both. It is not that development is not necessary, development is necessary, but how we manage balanced development with health is the key challenge that is facing us now. In fact, UN recently has accepted that NCDs are now a developmental issue, just like HIV is a developmental issue. So it is, even at international level now, we are trying to address NCDs as a developmental issue, not as a health issue. Again, this slide shows you that health is not determined by individuals, it is determined by social, community people, as well as general global socio-economic, cultural environment. And therefore, managing NCDs needs to go beyond health to address these challenges. With that understanding, let us go and see what we can do. When we talk of public health approach to NCDs, we talk of three things: surveillance, prevention, and control. We'll take each of them one by one and see what is to be done in each of them. We talk of surveillance. Surveillance is the basic backbone for any national program, any public health program. Surveillance provides you basic information. Without surveillance, we cannot do anything, because surveillance provides us information for program planning, surveillance provides information to see whether programs are effective. Are risk factors going down? Is disease going down? Is mortality due to NCDs going down? We need to know, and we need to know what is the current burden. Most, as you know, this is true also for communicable diseases. Surveillance is not only done for NCDs, it is done for every other disease. And we know that surveillance systems in countries like India are weak. We do not have a very good surveillance system or information system which generates robust information on these statistics, and therefore it is difficult to convince policymakers and program managers because you don't have information. So we need to invest on having better information on NCDs. And how does this information come? These are some of the sources that are listed in the slides. Cause of death, you need to know death and its causes by system of vital registration or medical certification of deaths. And now we have introduced a system of verbal autopsies on a sample survey. Compulsory notification of diseases, this occurs mainly for communicable diseases, this is not relevant for NCDs. Disease registries, like we have cancer registry, and there are places where we have stroke and diabetes registry, but it is very resource and technology intensive. We do surveys for, doing surveys for disease, whether it is cancer or heart disease, is not easy. To expect that at national level we will be doing surveys for these diseases is unrealistic. And finally is hospital-based information system, which is what most of us have in these countries. We know from many of the hospitals, though these hospitals, the system does not cover private sector, and we know almost 80% of patients are seen in private sector. So there is not sufficient information, our systems are not robust. So what should we do? WHO has what we call as a stepwise approach for surveillance. We are doing surveillance for three things: mortality, morbidity, and risk factors. And for each of them, we can, depending upon the resources that we have, we could look at a surveillance system which is very simple or a much more complex surveillance system. It shows for deaths, like just knowing death rates by age and sex without knowing the cause is the simplest way that we can do, or the final is to have a death by cause and by a death certificate, not by really a verbal autopsy, because verbal autopsy has its own limitations. For diseases, if we can do cause specific disease incidence or prevalence, that would be fantastic. But in the absence, we focus only on hospital-based information. And finally, for risk factors, which is what I will focus on. Again, I told you there are three levels of risk factors. Those are the three levels that we talk of in step 1, 2, and 3. Step 1 looks at purely behavioral risk factors. Step 2 looks at behavioral plus physiological risk factors. And step 3 looks at all the three, including biochemical risk factors, which is blood sugar and cholesterol levels. It is much easier to do risk factor surveillance, because rather than doing a disease survey or disease surveillance, it is much easier to define and diagnose whether a person has a risk factors, whether it is hypertension or tobacco or alcohol or diet, than finding out whether a person has a cancer or COPD. They require much more technology and much more intensive work, resource intensive. And finally, our intervention is going to focus on risk factor. So we need to know, if we want to know if our interventions are working, we need to know whether risk factors are going down. If we do know, if risk factors go down now, then the diseases will go down maybe after 10 years or 15 years. We won't know our interventions are working if we just measure disease till another 10 to 15 years, and it is not sufficient. We can keep doing something for 10 years without knowing whether we are doing a good job of it or not. We need to know within 2 to 3 years whether our efforts are showing results, and that can only come if we start acting on risk factors, not on diseases. And as I said, 80% of diseases can be explained by these 8 risk factors. It is much easy to do these surveys. And again, I discussed the steps concept. Step 1 looks at behavioral. So all you need to do is ask some questions, measure behavior by questionnaire. For step 2, which requires also blood pressure and anthropometry for obesity, you take some physical measurements. You don't need to collect blood. And if you want to do blood collection, that is step 3, you will also do blood sugar and cholesterol. And for each of them, we have a set of core questions which you should always ask, and then depending upon the time and resources that you have, you can always add more questions. Fully understanding that asking too many questions is not important. Surveillance is not research where you keep on asking questions. We need to focus, have very clear-cut questions and just stick to that. So if we have a good surveillance system, we could generate some of this data that I am going to show. We could generate some excellent data which will help convince the policymakers. This shows data from all the countries of Southeast Asia region on what is the prevalence of diabetes. This is data from cancer registry in India, again showing the incidence of cancer in India across from 1980 to 94. An excellent piece of information which shows us that there is a slight increase which is occurring in most of the cancers. You can see that some rates are in between 100 to 120, and now they are around 140. So think over about 25, sorry, this is for about 15 years period, the incidence has increased. This is data from Behavioral Risk Factor Survey of USA, and it shows how powerful, how obesity changed in USA over the period of the time that I am showing. In 1991, this was you can see the orange ones are where the obesity rates are very high, and the light blue are ones where obesity rates are very less, and as the blue increases, the level of obesity increases. In 91, there are very few states in USA which had obesity as a major problem. Many of them had reporting less than 10%, some of them 10 to 14. This is 1995. You can see that yellow has started increasing. Many states are now reporting which is more than 15 to 90%. In 4 years, majority of the states have moved from low prevalence of obesity to moderate prevalence of obesity. And this is another in 2000, another 5 years down the line, and now they are reporting obesity of more than 20%. So you see this, the power of data if we have of surveillance. This, no policymaker can be failed to convinced if you have data like this, that obesity is a problem which needs to be addressed as a public health approach. So what are the approaches? Again, the primary approach is risk reduction. We need to work on risk factors. There are 2 ways we largely target risk factors. One is a high risk approach, where the approach is the people who have high risk, people who are smoking, people who take alcohol, or people who are obese or hypertensive, and do something to bring them, decrease their risk. And the other is what we call as a population-wide approach, where we are not really looking at people with risk. We are addressing everybody in the population, irrespective of their risk status. So we are saying that everybody in the population should reduce their salt, not just people who have hypertension. The message is not that people who are hypertensive should reduce their salt. The message is that everybody in the population should reduce their salt. Everybody gains. If a person is taking 5 grams of salt, he will gain by taking 4 grams of salt. If they are taking 4 grams, they will gain if we reduce it to 3. So without waiting for, without just focusing on people with a risk factor, the message is how we can reduce salt consumption at the population level. That is the approach, rather than identifying people who are hypertensive and then telling them you don't take salt. And comprehensive approach looks at both. Obviously, we need to do both. High risk approach only targets people with high risk. We can't wait. No, this is not an ethical approach. We can't wait for people to develop hypertension and then say that we have only once you develop hypertension, we have a program for you. We look at both population based, where we address through the bulk of the distribution. All risk factors have a distribution, like blood pressure or whether it is cholesterol or sugar. A population approach shifts the whole distribution to the left. Everybody's blood sugar goes down, or cholesterol goes down, or blood pressure goes down. rather than looking at the extreme where people with high blood pressure or high blood sugar or high cholesterol. The key is, again, as a public health approach, is more importance is population based approach. At the same time, obviously we cannot leave people with a risk factor without doing something about it. We need to look at people with risk, but the focus has to be a population based approach, because that has a much larger and much more sustainable benefit. Unless you do something with population, people will keep developing risk, and you will have a program in perpetuity. You will keep treating people with hypertension forever. But as a population based approach has a possibility that over a period of time people with hypertension will go down, because they are shifting the distribution to the left. Where people with risk will go down, therefore the burden on the health system is going to go down. Otherwise, with an approach which is only looking at high risk, the burden will only keep increasing, it will never come down. So as I said, in a population based approach we shift the distribution. The one in the broken line is if it is the current distribution, we try to shift it to the line which is the continuous one. That is our approach in population approach as a public health approach. The red triangle is the people with high risk, and that is what we target on people with high risk. You can see that if the vertical line which shows right side to which, let's say, is that's say 140 80 as for blood pressure or 90 for blood pressure, then people to the right are people with hypertension. You can see that if you shift the distribution to the left, people who come to the right of that line have decreased. The triangle which was much bigger now would become very small, and therefore to decrease NCDs, we need to focus on shifting distributions of risk factors to the left. How do we do it? We do it by health promotion. We traditionally believed in health education, but we know that health education alone does not result in behavior change. We have to create an environment in which that education can be translated into an action. Just giving people information about that tobacco smoking is bad is not enough. People do not change their behavior. You have to make an environment which induces them to change the behavior or induces them not to take up this behavior. And that is what health promotion does. In addition to education, it creates and makes a healthy choice, as it says, an easier choice for people to adopt. People don't adopt healthy choices because of barriers. As you see, manufacturers profit from consumption of health damaging products. Heavy marketing of this thing. Nobody markets fruits and vegetables. And fruits and vegetables, you all are costing so high. It's outside the affordability range of most of the middle and lower income groups. So there is a barrier. People want to eat fruits and vegetables, but they just can't afford to eat it. So government has to have put policies in place which would make fruits and vegetables cheaper than the unhealthy foods which are available. Today, healthy foods are costlier than unhealthy foods. Obviously, in a country like India, which has which has a major share of people who are poor, they will go for unhealthy foods. You can't blame them. You can't say that they are choosing wrongly. They are being forced to choose wrongly because the policies are not in place to enable them to make an healthier choices. So we need to mold the markets, and through multi-front. This is not a job only of health sector. This is one of the things that NCDs cannot be managed by health sector. You have to look at industries. You have to look at consumers, and these are the policymakers and program managers. You need to look beyond health sector. It is not the job of health minister to control NCDs. It is the job of finance minister to see how we can. It's a job of food and agriculture department, how fruits and vegetables can be cheaper. It is the job of urban development ministry, how it can create more parks, more facilities for physical activity. So this kind of thinking has to occur at the highest level if we really want to create an environment where people can make healthier choices. This is a good example of tobacco. Tobacco is not unhealthy. All its consequences are health, but why people choose tobacco is not driven by health ministry. It is related to education. It is related to legislation. We have India has one of the strongest legislations in tobacco in the world. So which goes beyond that, covers tobacco trade. It covers tobacco production, which are not directly comes under the Ministry of Health. Economic alternatives of people who are cultivating tobacco. What do we do with them? So this goes beyond health sector. And tobacco has showed us that if there is a strong community mobilization and there is a strong willpower in the government, we can do it. It is yet to be translated into diet or physical activity or alcohol, but tobacco it has shown the way. And there is evidence to show that it has started working. And finally, as I said, we also need to improve our health system. It is not that the health ministry cannot do anything about it. We need to, our health, whether it is primary health centers, health workers, doctors, they are not yet into managing these diseases at primary level. These are still seen as diseases. Stroke should be managed at AIMS or tertiary care hospitals. MI should be managed in ICU. We need to get into a phase that these diseases, hypertension, diabetes, heart disease, can be managed at primary care level, at primary health centers. We have to make this happen. All of these drugs which are important for managing, whether it is hypertension, diabetes, heart disease, all these drugs are extremely cheap and can easily be made available at primary health center, and almost 70-80% of these diseases can be managed at PHCs, as is true for communicable disease, whether it is tuberculosis, malaria. All of these diseases can be managed at PHC. All of the NCDs can be managed at primary health center. We need to provide these drugs, we need to prepare those guidelines, we need to train people and have a good referral linkages so that people who cannot be managed at primary level are referred to secondary, and from there to tertiary. For some of them, maybe 5% of them would require a tertiary care. So this change in thinking of management of health NCDs has to occur. So finally, my key messages. You need to know that the NCDs are a major share of mortality and morbidity, and the trend is increasing. It is an equity issue. It is an issue. It's a disease of poor. It is a disease of where females are as much involved. It is a disease where rural people are involved. It's a disease where young and elderly all are involved. And we don't have good systems in place to really generate information which can help us convince policymakers and program managers strongly that this is something that they should take up. This increase is being driven by forces beyond health sectors like urbanization, globalization, market forces, and therefore a response needs to go beyond health sector. We need to focus on risk factors, whether it is for surveillance or for prevention, and we need to have integrated and comprehensive policies and programs which address not only health but also non-health determinants. And the health system needs a major strengthening to address these challenges at the primary healthcare level and not as a tertiary healthcare system. If you look at NCDs as a tree, the trunk is the risk factors, as you can say, unhealthy diet. So if you want to bring, if you just keep treating diseases which are like branches, unless you cut the trunk, the tree is not going to go away. You keep cutting the branches, it will keep growing up. You keep, which is similar to keep treating hypertensives or diabetics. You keep treating them, they will keep on coming. The cup will never be empty. You just, it's a process that will continue and continue. If you want to break the tree of NCDs, you have to attack the risk factors. So strike at the trunk and the diseases will automatically disappear over a period of time. I hope that covers most of the issues related to how to address NCDs as a public health problem.
Thank you very much, sir. In these discussions, actually, sir has covered most of all of the issue, starting from the disease burden and how these transitions has occurred, and after that he also discussed about these risk factors and the deficiency in our system, like surveillance as well as many other aspects of our health system. And he also gave emphasis that the health system is only one of the aspects, but rather than we have to work in a multi-sectoral approach. In this discussion, it also given priority that risk factors are the major key issue for the intervention of the disease. So I hope all of you must be benefited by these discussions, and here we would like to end the sessions, and at the end I would like to say thanks to Dr. Anand. I also would like to thanks to our EMPC team who is really making this program successful, and also viewers of all this program. Thank you very much to all of you.